Morning. How are you going, Caitlin?
I'm well, thank you, Bronwyn. Not bad for a Thursday.
Not bad.
Welcome everyone that's joined us.
Yeah, welcome obviously to the PACOP Morning Tea Talk, but also acknowledging Palliative Care Week, which we'll talk about in a sec. So as we start this meeting today, PACOP would like to acknowledge past and present traditional owners of this land, and we respect their continuing culture and the contributions they make to the life of this nation. We come to you today from the Dharawal Nation in the south of Sydney.
And I'm coming to you today from the lands of the Turrbal and Yagara people up in Brisbane.
And we also want to acknowledge, as I said before, the National Palliative Care Week 2023. And our part of this is putting palliative care and aged care front and centre with regards to the theme for this year, which is matters of life and death. And there's some amazing events for this National Palliative Care Week. So see what's happening in your state. Make sure you have a look at the Palliative Care Australia website for more information. We do have a link in this website, but it's very easy to access on going through Google as well. So today we are going to have a look at how PACOP and ANACC support people living in residential aged care. So the thing that we know about ANACC, and I think most people who are here with us today are familiar with ANACC, it's the Australian National Aged Care Classification Funding Model, which replaced ACFI on the 1st of October 2022. It was developed in 2018, and as an outcome of the Royal Commission into Aged Care Quality and Safety, the ANACC was legislated as the new funding model for residential aged care in 2022. So the benefits of the ANACC are that it improves accuracy and national consistency in assessments. It's a holistic perspective, including a resident's physical capacity, cognitive capacity, mental health needs, and it reviews behaviours and complex chronic care needs. So how does PACOP support ANACC? Well, PACOP program itself is a nationally funded aged care program for residential aged care. The earliest version was developed in 2019. It was piloted in 2019, 2020, and in collaboration with aged care homes, it was rolled out in 2022. So it provides a palliative care framework and processes in residential aged care, promoting holistic review of the residents, early identification of palliative and end-of-life care needs, and supports anticipatory care for residents and their families and carers. So you can see now we've got some level of alignment happening between the two tools. What we also know is that the PACOP and ANACC were developed by the Australian Health Services Research Institute at University of Wollongong. So PACOP is very aligned to the ANACC, and both programs use existing validated tools, of which there's an overlap of 3 tools: the RUG-ADL, the AKPS, and the Rockwood Clinical Frailty Scale. So here...
Rowan, can I just ask, so if there is an overlap of some of the tools, can you talk us through, as the slide says here, is this actually a duplication of ANACC, or what is really the difference between, say, using some of those tools in ANACC and then maybe using it in PACOP?
So I think what is important to say at this point, and that's such a good question, thank you, is that the ANACC and PACOP are 2 very different tools. They're completely different. And yes, there is an intersection or an overlap of those 3 tools, but when they're used in the context of the ANACC, they're looking at a full range of what is happening to the resident, and I'll show you what that looks like in a second. In PACOP, when they're being used specifically to assess palliative care changes. So there are some people who'll say, you know, ANACC is built into a number of the aged care software programs that are provided to software aged care for use for care planning. Well, we'll just use the ANACC RUG-ADL, Rockwood Clinical Frailty Scale, and the AKPS. The problem if you do that is, firstly, those tools are actually tools that are meant to be used by the assessors, the ANACC assessors, to evaluate residents. They're not specifically meant to be used by residential aged care staff. The focus is really on their documentation. And PACOP uses those 3 tools in conjunction with a whole lot of other tools that are all streamlined to show palliative care changes specifically. So cherry picking out of the 2 programs to try and do some of that assessment means that you are not doing any, you're not really using the tools correctly. You're not using programs correctly.
But and also I think residents can change. So the time that they get or have had those assessments done with their ANACC, and then time has passed, and when they're having their PACOP assessments done, they might not necessarily be exactly the same score or rating for some of those either. So I think we've got to be really cognizant and careful around that as well.
Yes, well, some of those PACOP ANACC assessments can only be reviewed every 6 months. Whereas with PACOP, I mean, the minimum assessment is every 3 months, but you can do those assessments more frequently if you want to. And built into the PACOP profile collection is a deteriorating resident tool. So you can actually monitor your residents at any point of time for any changes that are happening. And you're using those, and always, just to reframe, PACOP is always about palliative care. So when you're looking at those tools and you're doing those assessments, you're looking at palliative care changes, which once you've had a look to see what's going on with those residents, formulated your care plans, you actually then can go back to your ANACC and have a look to see if this resident qualifies for any changes. So there are two very different programs, but they do have that overlap, as we discuss. But the overlap is not interchangeable. So here you can see the tools that are used in the ANACC, and you can see here that they talk about palliative care details, right? So it's a comment on there are questions that the ANACC asks about palliative care, but they're quite perfunctory. They're not really in depth.
So there is a palliative care component of ANACC, but what does that actually mean, and what does that look like, and how does PACOP feed into or support that?
Okay, so when you have a look at the ANACC reference manual, particularly page 10, it says there that, and I'll quote, an active palliative care plan can be formalized, a formalized care plan or documentation in the resident's notes. So formalized care planning, you know, PACOP fits into that genre or into that context. The document, but the thing about PACOP too is that you always need to do PACOP plus documentation. So the strength of the program is the formalized care plan and the documentation in the resident's notes. When ANACC talks about palliative care details, it also says a palliative care plan includes documented instruction relating to palliation by the GP or other health professionals. And this may be that you're looking at medication changes, end-of-life treatments, and so on. So that ties into beautifully with when you've got things like palliative care needs surrounding specialist palliative care teams coming into play, any kind of in-reach teams happening in aged care. These all contribute to the palliative care planning, which then, if you go backwards in this slide, it is part of that palliative care details and then becomes part of a consideration from an ANACC perspective around what's happening to the resident.
So rather than interpreting that and using what assessments and things that a home may have pre-existing, using PACOP can actually be a really good standardized way of putting a piece of evidence in to fulfill that.
And it does. You're absolutely right. So, you know, having come from an aged care background previously, a lot of the approaches that we had to palliative care were ad hoc. And if you weren't skilled in picking up changes in what was happening to a resident, palliative care changes, and sometimes it's very difficult with the group of people that we look after in residential aged care, you would miss the opportunity to identify change. So what PACOP does is it actually streamlines the whole approach to assessment. So we're going to talk about ANACC Class 1 here, but it actually looks at all people who are living in residential aged care. So in the context of ANACC Class 1 admit for palliative care, what we know about that classification is a resident is assessed externally by people who are not employed by the aged care facility. So any kind of practitioner, so it can be a doctor or a nurse practitioner. There are some criteria that the resident needs to meet. Once they've met that criteria, then the aged care home needs to say, yep, we can do the palliative care for this resident. We're happy to take that on. The resident will come in as a palliative resident. And then the family and or the resident need to sign off on it. So it's got 3 parts to it. When the aged care home admits that resident, if they are looking for, you know, a palliative care approach and a palliative care plan, PACOP actually services that need beautifully. Because you've got the palliative care, in PACOP, you've got profile collection, which is your routine, regular assessment of your resident. at a minimum of every 3 months, but you can do that more frequently if your residents
Right.
have a high level of acuity. Built into profile is your deteriorating resident tool.
Mhm.
But with a resident who's coming in as a ANACC Class 1 admit for PAL care, they obviously have palliative care needs, which is what the outcomes collection provides support for. So the outcomes collection is the palliative and end of life part of this program that we work with.
Right.
So a resident coming in as an ANACC Class 1 would go into profile and straight into, or transition straight into the outcomes.
Because they have that concentrated high need already.
Correct. And it's been identified externally.
Yeah.
And the ANACC has clarified that, and the classification identifies that. So they have to come in for palliative care. But at the same time, with PACOP, every resident is reviewed on a routine basis using profile.
Regardless of their class.
Regardless of their class.
Yeah.
And what profile collection does is it actually starts to identify the changes, because we're looking for trends. So every month or every 3 months when you're doing your assessment, that the PACOP program goes through systematic review of the same things each time. So you can pick up trends, and that can help you to identify the changes that are, if you're looking for an ANACC reclassification, it can help to actually give you the information you need around that if you feel that your resident has had significant change.
But it also paints a picture of your resident cohort as well, if you're assessing everyone, rather than just some residents that you might take the opportunity or may use your initiative to reassess or think that they have high needs.
Yes.
This is painting the picture for everyone.
It is painting the picture for everyone. So in light of that, how does PACOP identify palliative care changes and end-of-life care needs? So in the profile collection, which is that routine, regular assessment of the residents, once you've done all those assessment tools that we were talking about, and we have a look at diagnostic clusters, end-of-life care planning, advanced care planning, and we look at hospitalization, the next step is identifying the needs of palliative care or need for palliative care. So there's a series of questions that the staff who are completing profile work through to help them to identify if this resident has palliative care needs. So the top 5 questions you can see on this slide here directly examine whether the resident has already come in with a palliative care plan, or if a palliative care plan has been developed, for example, by GPs or specialist PAL care. So, the resident has a document palliative care need by a GP or PAL care health professional team, or a plan that's already been developed. And you can see there, it talks about ANACC Class 1 at the top, and whether a resident has been admitted from a palliative care unit. So the first 2 questions are about new admissions. The remaining 3 questions there are about people who are currently in the aged care home. Of the 5th question there, based on clinical judgment, the current assessment and all information available to you, do you believe this resident has a prognosis of less than 3 months? So if you say yes to any of these 5 questions, or a yes to 2 of the 3 assessments below. So here, this is talking about the assessments you've just done in your profile. You will have assessed the resident looking at the SAS, the problem severity score, the PSS. You'll also have done your AKPS and Rockwood Clinical Frailty Scale. So if you've got moderate or severe symptoms in the SAS or PSS, or an AKPS of 40 or less, or a Rockwood Clinical Frailty Scale of 8 or 9, 2 of those will really identify that that resident has palliative care or end-of-life care needs. And this is where PACOP recommends that the resident is transitioned to the outcomes program. And the other thing that happens in profile, which is amazing, is that there's an actions list, a way of helping or supporting staff to along the decision making and the care planning that needs to happen, having identified PAL care needs.
I think, Bronwyn, that's also really supportive for those with varying levels of confidence and knowledge around palliative care in an aged care home as well, because you might have some people in the team that are really confident and know what to do, others not so much. But having a standardized sort of action list to follow helps everyone effectively do the same thing and follow the same prompts and steps to be able to action things for a resident.
And it does, because we talk a lot about the staffing in residential aged care, and we know that there is a problem with workforce at the moment. We also know that there is a lot of work happening around retraining staff and bringing staff into aged cares, RNs. So we're going to have a lot of new staff in the aged care setting who have never worked with palliative care before.
Yeah.
And we often have organizations and aged care homes talking to us about, well, you know, what do we do with new people? How do new people know how to do these assessments? And the answer to that is having a standardized program like we have, and validated tools, and a very clear, direct process. People who are new will be able to assess residents with palliative care needs and identify palliative care needs as much as that skilled person will be able to do.
Yeah, 100%.
Yeah, and you know, we recommend that when the staff are doing their assessments, that they have conversations with their peers and talk to their peers. So there's two reasons for that. One is that there's a lot of learning that can happen from people who may be senior. But if you're a group of junior RNs, having a combination conversation or collaborative conversation means that no one person is making a decision. There's no single point of decision making. It's a shared decision, and it has a lot more benefit to the resident, but it also protects and supports the nurses that are involved in that discussion. So one of the things that PACOP does as well is it has an electronic version of the program.
Wonderful. Yeah.
So this program is available to be uploaded onto the computers, and all the documentation for PACOP is embedded in this. So it's a clinical tool. And we are working with the software programs that are provided to aged care, building PACOP Pal Center into those programs so that it can be used as a single software program instead of having two, because at this point in time, a lot of the aged care homes we're working with have their official data, that software program that they use, and they also are using PACOP Pal Center. So I thought I might just show you what that would look like if I was working in an aged care home. This is what the landing page would look like with all my residents. So here is an example. It's a mock example of what an aged care home might look like. So every single resident is in profile. Every single resident is assessed. And here are a group of residents who are identified as being in outcomes collection, which is our palliative and end-of-life care part of the program.
Not all residents will need to be going into outcomes to have that concentrated support or that high needs support. Only some of them will.
Only some of them, yeah. So, you know, in the aged care homes that we're working with at the moment, the average that we're seeing is between 10 and 20% of the residents. I do have one aged care home that had nearly 50% of their residents in outcomes.
Wow.
And we did a big check to see if that was an incorrect assessment. And what was found was that actually tied in with their quality indicators, and it was part of a general deterioration of the whole group of the aged care home. So the benefit of this program is that it's going to drill down for individual residents, but it also gives you a spectacular overview of what's happening from a palliative care perspective in your aged care home. So when you have a closer look, you can see this says that, you know, these residents are in outcomes. The other thing that's phenomenal about this program, I think it is, as a clinician, you have the ability to go into this section of the program, and you have an overview of everybody with their palliative and end-of-life symptoms, and you've got a traffic light system that helps you to triage. So when we talk to people who are using Pal Center with our aged care homes and teach them, we talk about the benefits of this. So a GP coming into your aged care home, your specialist PAL care team that are servicing, or your geriatric flying squads or equivalent, the rapid response teams that come in and support aged care homes, can all have access to this, read-only access to this. They can log in and they can have an overview of what's happening. If I've been on leave and I come back in as a you know, fresh from a days off or whatever, I can come in here and I can have a look to see who I need to respond to. I can triage all my residents to see whose needs are greatest. And this is the drill down. So those previous ones were looking at an overview of everybody in the facility. This then drills down on the individual person. And here I can see assessments that have been done on different days, with the resident having been in different parts of the program. So the purple part is the routine regular assessment. The green is the deteriorating resident tool, and the orange is outcomes. And this is an example of a journey that a resident may be taking through their end-of-life process. So,
yeah, I was about to ask, how does all of this link into ANACC, and how can we use this in terms of, ANACC classifications or reclassifications?
So I think we have to make sure that everybody knows, doesn't matter what tools you're using, if you don't document, if you don't document the outcomes of the tools, and you don't document what that information altogether means, like the synthesis of that information, there's no point in any of the assessments. So you have to obviously do your assessments, but you have to document, because the documentation is where anyone who's doing
backs it up.
Yeah, it does.
Yeah.
And when you've got your ANACC reclassifications, they are going to, the people that are doing these reviews will come and they will look at the notes. So we've had a lot of people who have spoken about not being successful in being reclassified. And then when we talk about their documentation, they will comment that their documentation is below par. And that's the reason why the reclassifications are not happening. So you can do all these assessments, but if you're not documenting, there's no point.
So in real life, if I was scoring and filling out PACOP profiles and outcomes, all of those scores, numerical scores, need to be backed up with written notes.
That's right. So you would use that, we saw the decision-making matrix beforehand and the actions. They would then guide your planning around what was happening to your resident. And you would explain that because of all the scores, because of this matrix, the decision or the outcome is you're moving this resident into outcomes, and you'll be monitoring them on a daily basis to check for all their palliative care needs and symptoms and intervening, as is appropriate accordingly. So the information that is incredibly valuable from a reclassification perspective, obviously it's quality indicators. It's PACOP, because we bring that palliative care perspective into the documentation and assessments. And then I've put here the SIRS program. So that's the Serious Incident Response schedule. So it's sorry, I probably used the wrong language there, but it's a serious response incident reviews. And if you've got an escalation in someone's behaviors in your aged care home, we often look for the immediate issues, but we don't necessarily always look at the bigger picture of what's happening to a resident.
Zooming out and being able to see everything.
And if you zoom out a little bit and you consider what's been happening to the resident and what has happened preceding this change of behavior, and what the behavior is responding to and not responding to, it's quite possible that this change of behavior is actually an end-of-life event. So the SIRS reviews are really important, because it could be your first warning that a resident is moving into an end-of-life care status.
Yeah, it's also like being aware that the needs and the ANACC that was reflected when someone enters a home may be very different to what that person is like now, or their needs now. So, being able to be cognizant of that and suggesting and thinking about reclassification if they do fit that criteria. All these points of data collection or information can help back that up and support that.
They can. So, the main issues around reclassification are, from an ANACC perspective, are change in mobility, and there's 3 classifications for that. Hospitalization, there's 2 classifications, and they're current classifications. So if someone's currently classified as a 9 through to a 13, you have a 6-monthly review, and if they've got a classification of a 2 through to an 8, they are reclassed or reviewed every 12 months. That's just an automatic review. But if someone's come back from hospital and there's significant changes, if there are changes to mobility, those will be implicit in reviews or requesting reviews. And often what we see with the reviews that we do from a PACOP perspective is mobility becomes a big issue. So there is the capacity to use your PACOP assessments to assist with your review of your residents and the changes that are happening to those people. And then I think the final thing that we really want to talk about is how much PACOP actually supports continuous improvement initiatives. So facilities, aged care homes that are participating in PACOP have the ability to send through de-identified data that they've collected for our PACOP team to review and to synthesize, to check through the information. So everything that is collected in the assessments can be reviewed and evaluated. So this is an example of a dashboard that would be sent with a full report every 6 months. And you can see here, this is profile. There will be one for outcomes as well. And every point of information that is collected in profile is in summary, illustrated summary in these 2 pages. So having a closer look at a couple of things I want to look at. One of the things that has not really been well explored in aged care is the actual complexity of care needs. So the diagnostic clusters. And when you look at the burden of care and the burden of illness on this group of people, it's quite significant. So one of the things that PACOP is looking at providing information around for aged care homes is, to what degree does this aged care home have a number of residents who've got multiple comorbidities, multiple clusters? And how does that change the acuity in that facility? So what we've got here is, when we do the diagnostic clusters in profile, one of the questions that you're asked is, what is the current main reason for care when you're doing this assessment? And in this aggregated data from this report, you can see that in this particular facility, residents, there were 40% of the residents that had palliative care needs.
That's a huge amount, really.
Huge amount. So, you know, if I am a manager of an aged care home and I get this report, and this is one of the things that the improvement facilitators, you and me, will be working with the aged care homes, is what does this information mean? I've got this huge group of people who've got end-of-life needs that can see that about 25% of them, a quarter of them have got cognitive impairment. And when you look at this, this is not just in different people. These are overlaps in a number of people. When you look across here at all reasons of care, you'll see that in this 40% of people with palliative care, end-of-life care needs, they also have cognitive impairment, neurological conditions, advancing frailty, organ failure, psychosocial issues, and a small percent of them have palliative care, have cancer needs as well. So there's 2 things here. You've got your main reason for care. 40% of your residents are having palliative care. And your diagnostic clusters here are showing you the huge burden of illness that this group of people are experiencing. So that's one point where you would go, okay, wonder what we're doing from an ANACC perspective, how this is actually correlating.
How can we actually use that? What questions do we need to ask about our resident cohort?
That's right. And how well are we documenting all of that? So these are the 2 palliative care tools that PACOP uses. So the SAS, the Symptom Assessment Scale, and the PSS, Problem Severity Score. The SAS is an amazing tool. It's a resident-rated outcome measure. And we get the resident to tell us about what's happening to them and the distress that they have around their symptoms. So you can see here in this aggregated data, the residents were documented to say that 40% of them were experiencing distress from pain, fatigue, other. So other's great. It captures a variety of things. So we've actually got to document what those are. And in information we've already reviewed around the SAS previously, it's told us that there's often symptomatically issues around itchiness and skin, and also anxiety. But you can see there's a range of, there's actually 7 different symptoms that are reviewed there. And from the problem severity score, you're looking at the moderate and severe issues around pain, other symptoms. And this is where RNs and ENs have the ability to do some.
So that's the clinician rated tool.
Yes, and it's like, what is my priority of care when I'm looking at this resident? So these 2 tools are your palliative tools, and these, when you drill down on them, actually start to demonstrate, or continue to demonstrate the acuity of your resident and the palliative care needs of your residents. And this is one that I think is phenomenal. So here we've got the AKPS, the Rockwell Clinical Frailty Scale, and the RUG ADL, and these are the tools that are also in the ANACC, but here they're being used with regards to what's happening from a palliative care perspective for the residents in this particular aged care home. And what you can see is with the AKPS is the Australia Modified Konofsky Performance Scale, that you've got probably, when you look at this, about 50% of your residents are sitting in 30, 20, and 10. So 20 and 10, when you score that for a resident, you're looking at palliative and end-of-life care. In the Rockwood Clinical Frailty Scale, again, you've got more than 50% sitting at 7, 8, and 9. So 7 is severe frailty and can also have an overlap with cognitive impairment, severe cognitive impairment. And 8 and 9 are levels that indicate that these people are really close to end of life, and an opportunistic illness could take them and it would be the end of their life. So very frail, close to end of life. The RUG ADL, you can see the bottom 3 there. Again, you've got about 50% of your residents are sitting at 16, 17, and 18. That's telling you that you've got about, at least 2 people looking after this person at any one time, and equipment.
Very high needs.
Very high needs. So in this aged care home, you've got lots of people who are palliative, end of life, very high needs. But when you look at their ANACC scoring, the ANACC classifications, there's a miscorrelation. So as a manager, I would find this very useful to have a look at, because it would make me go, what's happening here? So in the profile, there is the ability for staff to document the current level of the resident from an ANACC perspective, and also if there needs to be an ANACC, consideration for an ANACC reclassification.
100%.
Obviously, the information in this report will be as good as the information that the staff are entering. So that could be the problem here. But if, let's say, those were accurately entered, then this could also be an indication that haven't got the right classification for our residents. And why? What's that about?
It'll just create that opportunity to ask those questions, do a bit of a deep dive, and work out who might we want to consider for reclassification, and if they are in fact meeting the criteria for that.
That's right. And have we documented properly? Because what may have happened is we've asked for a reclassification, but the documentation wasn't there to support it. So I think the point is, when we looking at these tools, being the dashboard and the report for aged care homes, as improvement facilitators, we can work with the aged care homes that we're working with, and we can talk to them about what this all means. And this is how we set up continuous improvement initiatives. So, anyone who is participating in PACOP, any aged care homes and aged care organizations, our roles, improvement facilitators, we work very closely with them, and it's a free service, if you like, because it's part of the Department of Health and Aged Care national funding. That's PACOP is an aged care funded program. And we provide training workshops, communities of practice. We turn numbers into knowledge. I love that statement. We work with quality improvement, and we also do national benchmarking. So we have this ongoing continuous relationship with the aged care homes and organizations we're working with, and we're hugely invested in making sure that palliative care becomes an easy business as usual process for aged care homes.
And on that, Bronwyn, I'm just cognizant of the time. Does anyone have any questions or anything that they would like to ask us while we're here live at the moment? Feel free to put it in the chat.
Any questions that have come up? Oh, we've got a chat up there. Thank you, Janelle. Janelle's put in, and I know you can all see this, I've got it on the screen. There's a guide for best practice for effective incident management systems available. So that's the SIRS link. Okay. All right. So any other questions that have come up? Okay. So one more.
May I have a copy of the presentation today? I have a meeting at 10 a.m. tomorrow for my managers. Of course you can. We will be putting this up on our YouTube channel. And I believe that we send some of the registered participants a copy and links after we finish the presentation today.
Okay. Well, thank you everybody for your time today. The references to the things that we've spoken about today are actually in this. I will add that SIRS reference as well.
Yeah.
And thank you for joining us.
And see us all next month when we are having a morning tea talk on the 29th of June on the PACOP SAS. We'll see you all then. Thank
Thanks
you. Bye.
everybody. Bye.